You know, I feel like usually when we talk about a medical diagnosis, there is this clear expectation of precision. It almost feels like engineering.
Oh, definitely. Like a broken bone or
Well,
something.
exactly. You break your arm, the x-ray shows this jagged white line, and the physician points at the film and says, well, there it is. It's binary, broken or not broken.
You wish it was always that simple.
I know, right? But step into the world of acute critical care, and suddenly that x-ray machine is showing you an absolute medical mystery. I mean, imagine looking at a patient's chest x-ray. It's completely whited out, dense with fluid, looking exactly like classic severe congestive heart failure.
Which is terrifying to see on a film.
Absolutely, but here is the catch.
Mhm.
The patient has a completely normal heart. Like, the pump is working flawlessly.
It is the absolute definition of diagnostic muddy waters. I mean, if you treat that patient for heart failure based entirely on the way that X-ray looks, you are going to give therapies that might actually accelerate a total systemic collapse.
And that is the mission for our deep dive today. We're exploring a phenomenon described in our sources as when systems cascade. We are looking at shock lung and multi-organ failure.
It's a heavy topic for sure.
It really is. We are going to use historical medical journals, modern diagnostic criteria, and everything in between to understand how one single bodily failure can trigger an entire chain reaction. So, okay, let's unpack this.
Well, what we're analyzing today isn't just about, individual organs getting sick. It's about what happens when the body's highly interconnected network turns its own defenses against itself.
Right.
We're looking at systemic dysfunction where survival really comes down to understanding these invisible runaway feedback loops inside the patient.
Let's actually solve that medical mystery right out of the gate. Why does the x-ray look exactly like heart failure if the heart is perfectly fine? Reading through the sources, the best way I could visualize this was by comparing the body's cardiovascular system to a house's plumbing.
That's a really good analogy, actually.
Thanks. I mean, if you walk downstairs and your basement is flooded, your first thought is usually, well, the water pump is broken. It isn't moving the water out.
Which in the body, that is classic congestive heart failure.
Exactly. The medical term is hydrostatic edema, right? The heart fails to pump, pressure backs up, and fluid spills into the lungs. But what we are talking about today is fundamentally different. The pump is fine. Instead, the pipes themselves have become porous. They are leaking everywhere.
Right, and the medical term for those leaky pipes is permeability edema, or non-cardiogenic pulmonary edema. It's the single most important distinction in this entire topic.
And that's what they used to call shock lung.
Exactly. The old bedside term for this was shock lung, but today it's known as ARDS, acute respiratory distress syndrome. It's the sudden, severe form of respiratory failure where the tiny capillaries lining the alveoli, the lungs' gas exchange sacs, they just become abnormally leaky.
So instead of staying inside the blood vessels where it belongs, all that plasma, protein, and inflammatory cells just flood right into the air spaces.
Yes. It's literally as if the walls of the pipes just dissolve.
Wow. What really stood out to me in the sources is how much trouble the medical community had just trying to define this accurately. Because if the diagnosis relies on distinguishing between a broken pump and leaky pipes when the x-ray looks identical, standardizing that for research seems nearly impossible.
Oh, it took decades to standardize. I mean, in 1994, the American European Consensus Conference, or the AECC, established a definition using a very specific mathematical cutoff.
What were they measuring exactly?
They looked at the oxygen level in the blood divided by the inspired oxygen fraction. So they set a ratio of 300 or less alongside bilateral chest X-ray infiltrates, and crucially, they required no clinical evidence of heart failure.
But the sources show the medical community eventually realized they were casting the net way too wide with that 1994 definition, right?
Yeah, they were. And what's fascinating here is how the definition had to evolve to reflect the actual underlying mechanics of the lungs. By 2012, an international task force led by Luciano Gattinoni and V. Marco Ranieri published the Berlin definition in JAMA.
And that changed things.
Massively. They realized the old definition was capturing patients who didn't actually have the same disease physiologically. So the Berlin definition discarded the older, vaguer category of acute lung injury entirely.
Oh, I see.
Instead, they split ARDs into mild, moderate, and severe tiers based on that same oxygenation ratio. But the critical addition, the really big change, was requiring a specific metric on the ventilator, which is PEEP, or positive end expiratory pressure.
I actually want to pause on PEEP because the mechanics of it seem so central to why the 2012 definition was such a breakthrough.
Sure. So PEEP is essentially the baseline pressure the ventilator leaves in the lungs at the very end of an exhale. Think of a wet balloon.
Okay, a wet balloon.
Right. If you let all the air out of a wet balloon, the wet sides stick together, right?
Yeah.
And it takes a massive amount of force to pry them open again with the next breath.
Yeah, that makes sense.
So PEEP keeps the balloon slightly inflated so it doesn't collapse. By requiring a minimum level of PEEP during the diagnosis, the Berlin definition ensured doctors were evaluating lungs under standardized mechanical conditions.
Oh, wow.
Yeah, it tightened the parameters so researchers knew they were actually looking at true permeability edema, not just lungs that had, temporarily collapsed.
That is brilliant.
Yeah.
But if this syndrome is fundamentally tied to the way we measure pressure on a ventilator, I'm really curious about the timeline here. Reading the history, ARDS and its broader cousin, multiple organ dysfunction syndrome, or MODS, they seem relatively new in the medical literature.
They are, relatively speaking.
So did human biology change, or did our tools change?
Our tools changed. Definitely our tools. The clinical entity was first clearly described in 1967 in The Lancet by David Ashbaugh, Thomas Petty, Bigelow, and Levine.
And they were looking at adults, right?
Right. They described 12 adult patients. And it was a mix. Some had trauma, some had pancreatitis, some had viral pneumonia. But they all developed a strikingly similar pattern: severe breathlessness, stiff lungs, diffuse haziness on the X-ray, and a total resistance to oxygen therapy. And again, no heart disease.
So how did they know what to call it?
They actually deliberately modeled their description on infant respiratory distress syndrome, where premature babies lack the surfactant that keeps air sacs open. They saw the physiological similarities and dubbed it adult respiratory distress syndrome, which they later changed from adult to acute when they realized pediatric patients could get it too.
But the visceral origin story of the term shock lung comes from combat surgeons during the Vietnam War, doesn't it?
Yes, exactly. They documented this really distinct biphasic pattern.
Well, right, because a soldier would suffer a massive hemorrhagic injury, losing just liters of blood. They would be aggressively resuscitated with IV fluids and transfusions in a field hospital. And they would survive that initial hemorrhagic shock and look perfectly stable for 24 to 48 hours.
But then, days later, they would abruptly crash. They would develop those stiff, fluid-filled lungs. It was as if surviving the first physiological hit planted this delayed action bomb.
That is terrifying.
It is. This two-hit pattern convinced military doctors they were looking at a completely distinct disease process, which they referred to as shock lung or Da Nang lung.
This actually brings me to a detail in the surgical papers from the 1970s that shifted my whole perspective on critical care.
Oh, which one?
Looking at the work of surgeons like Nicholas Tilney, Gerald Bailey, and Alexander Morgan in 1973, and Arthur Bau's highly influential editorial in 1975, Bau literally named it a syndrome of the 1970s.
Wait, so are you saying intensive care units actually created a new disease?
I am. Prior to the invention of modern ICUs, ventilators, and dialysis, multiple organ dysfunction syndrome just did not exist as a recognizable clinical entity.
Because people didn't survive long enough.
Exactly. If your lungs failed in 1950, you died of lung failure.
Yeah.
You never lived long enough for your kidneys or your liver to fail a week later.
Bau and his colleagues were documenting patients who survived emergency vascular surgery, like a ruptured abdominal aortic aneurysm, only to lose organ after organ in the following days. Lungs, then kidneys, then liver, then their blood's ability to clot. Modern technology was keeping patients alive just long enough for the sequential failure of multiple systems to become visible.
Here's where it gets really interesting. If survival from that first hit allows the cascade to happen, what is actually driving it? How does a ruptured aneurysm cause your lungs to fail and then your liver?
So, to understand the mechanism, you have to look at the body as a highly interconnected network, not just a set of independent machines.
Right.
A single triggering insult sets off a whole body inflammatory cascade.
Yep.
It is not the original physical injury spreading. It is the body's own chemical alarm system just going completely haywire.
Oh, like a cytokine storm.
Exactly. Massive release of inflammatory signaling molecules like TNF-alpha, IL-1, and IL-6 leads to systemic inflammatory response syndrome, or SIRS. These cytokines act system-wide, making capillary walls everywhere abnormally leaky and activating white blood cells and clotting factors indiscriminately.
The sources mention a concept called sterile SIRS. That is a massive paradigm shift because it means you do not need an infection like sepsis to trigger this systemic inflammation.
Right. Sepsis is definitely the most common trigger, but the body responds to massive tissue damage with the exact same cascade it uses for a massive infection. Severe trauma, burns, massive surgery, or severe pancreatitis can all trigger sterile SIRS.
A concrete example of this from the sources that blew my mind is a patient with a fractured femur, a major bone break, and yet the very first organ to fail is their lungs.
Yeah, it seems disconnected, doesn't it?
It does. I imagine the lungs acting like a giant fishing net. Because they receive 100% of the cardiac output through capillaries that are barely one cell thick, they catch all the inflammatory debris.
That's a perfect way to look at it. Your entire blood volume has to squeeze through those microscopic pulmonary capillaries on every single loop through the body.
Wow, every single loop.
Yes. So when the blood is full of angry inflammatory cytokines or fat emboli released from the marrow of a broken femur, the lung capillaries are the first ones to take the hit. They are the sentinel organ in the cascade.
So they fall first.
Right. Once the lungs fail, the process accelerates. If the underlying inflammatory drive isn't controlled, that leaky capillary clot and inflame process spreads. The injured kidneys lose their ability to filter the blood, leading to acute kidney injury. Then the liver starts failing, unable to clear toxins, shown by rising bilirubin and clotting abnormalities.
And the brain too, right? The sources highlight delirium and encephalopathy.
Yeah.
It is a true whole-body collapse, which clinicians actually quantify using the SOFA score, this sequential organ failure assessment.
Yes, developed by Vincent and colleagues in 1996.
Right. It translates the qualitative concept of organ failure into a trackable number across 6 organ systems.
And the mathematics of that score reveal the true danger of MODS. Organ failures multiply risk. They don't just add it.
Wait, really? They multiply?
Yeah. If you have 2 organs failing, your mortality risk climbs steeply and disproportionately due to this deadly physiological synergy. Injured kidneys can't clear the inflammatory mediators from the blood. A failing liver can't detoxify the circulation. The injured gut starts leaking bacterial products into the bloodstream, which just dumps more fuel on the original inflammatory fire.
Okay, I am struggling with a concept in the sources regarding how doctors actually intervene in this cascade. Let's look at ischemia-reperfusion injury.
Oh, that's a tough one.
It is. If tissue is actively dying from a lack of oxygen during a state of shock, how can restoring blood flow and oxygen back to that tissue possibly be the thing that damages it? It seems completely paradoxical.
It is one of the most counterintuitive mechanisms in medicine, honestly. During the period of ischemia, when the tissue is starved of oxygen, the cells can't maintain their normal metabolism. So toxic metabolic byproducts start piling up inside the cells.
Okay, so the garbage is building up.
Exactly. When you finally restore blood flow, which is the reperfusion phase, that subtle rush of fresh oxygen interacts with those accumulated toxins. And this interaction generates a massive burst of reactive oxygen species, also known as free radicals.
And free radicals are bad.
Very bad. These free radicals literally shred the cellular membranes and trigger intense local inflammation. So the life-saving act of restoring blood pressure can inadvertently pour fuel on the systemic inflammatory cascade.
Wow. So you're saying the very things keeping the patient alive, like fluids and the ventilator, can actively trigger the cascade they're meant to stop?
Unintentionally, yes. That paradox applies to the IV fluids used to restore that pressure, too. When a patient is in shock, their blood pressure is dangerously low. The intuitive response is to give aggressive IV fluids. But if the capillaries are already leaky...
The fluid just doesn't stay in the pipes.
Exactly. That excess fluid does not stay in the blood vessels. It leaks out and pools in the tissues. In the abdomen, this fluid accumulation can lead to abdominal compartment syndrome.
Which sounds awful.
It is. The pressure inside the belly becomes so high, it physically crushes the kidneys, stopping them from filtering, and pushes up against the diaphragm, restricting the lungs. It is an iatrogenic, or treatment-caused, contributor to the very organ failure cascade doctors are trying to prevent.
That is wild. And the most dramatic example of the treatment becoming the trigger involves the ventilators, right?
Mm-hmm.
For decades, the standard practice was to give patients large breaths of air on the ventilator, around 12 milliliters per kilogram of body weight. The biological logic was just that bigger breaths deliver more oxygen.
Which makes sense on paper.
Right.
Yeah.
But then the ARDS-NET trial was published in the New England Journal of Medicine in 2000.
Yeah, and the ARDS-NET study proved that biological logic completely wrong at the bedside. They compared those traditional large breaths to smaller, gentler tidal volumes of around 6 milliliters per kilogram.
Half the size.
Exactly half. And the smaller breaths dramatically reduced mortality, dropping it from roughly 40% down to 31%.
The explanation for why the larger breaths were so deadly fundamentally changes how you view a ventilator.
It really does. The large breaths were causing what is called volley trauma. They were physically overstretching the already fragile, inflamed alveoli with every single breath. The ventilator itself was tearing the microscopic lung tissue, actively causing ventilator-induced lung injury, or VLI.
So the machine is causing trauma.
Yes. This mechanical trauma was releasing even more cytokines into the bloodstream, driving the multi-organ failure. It is one of the most consequential trials in critical care history because it forced a complete worldwide shift. Gentle ventilation saves lives.
The sources repeatedly highlight this theme of medical humility. The realization that what makes sense in a laboratory model doesn't always translate to the ICU. Take early goal-directed therapy, or EGDT.
Oh, that's a classic example.
Right. In 2001, a single trial suggested this incredibly aggressive, protocol-driven fluid and medication resuscitation for septic shock was a miracle cure. It became absolute dogma worldwide. But then, between 2014 and 2015, three massive international trials process, ARISE and PROMISE, found it had zero mortality benefit over just good standard routine care.
And we saw the exact same humbling reversal with the drug Zegras, or drotricogenofa.
Oh, what happened with that?
Well, it was approved by the FDA in 2001 based on the PROWESS trial. The biological plausibility was flawless. It was a recombinant activated protein C drug designed specifically to stop the runaway clotting and inflammation in severe sepsis.
Sounds perfect.
It generated enormous excitement. It was added to international guidelines everywhere. But a decade later, the mandatory confirmatory trial, PROWESS Shock, found absolutely no survival benefit. The manufacturer voluntarily withdrew it in 2011.
Wow, 10 years later.
Yeah. It was a stark lesson that biological plausibility does not guarantee clinical benefit when you are dealing with a cascade as complex as human inflammation.
That complexity is perfectly illustrated by the ongoing debate about the gut's role in this cascade. Surgeons like Carrico, Meekins, and Marshall proposed this elegant idea in the 1980s and 90s that the gut is the motor of MODS.
Right, the bacterial translocation theory.
Yeah, the theory was that shock injures the gut lining, allowing bacteria to translocate across the bowel wall into the bloodstream, continuously driving the systemic inflammation. But later research, like the work by Edwin Deitch, struggled to actually prove this bacterial translocation happens consistently in humans. It remains contested to this day.
It really highlights how much of the pathophysiology remains a frontier. I mean, some researchers still debate if MODS is a single uniform disease or if it is just the final common pathway where many different severe illnesses converge, basically wiping out the initial trigger-specific differences as the body shuts down.
So what does this all mean for you listening right now? Why does the intricate pathophysiology of leaky capillaries and sterile SIRS matter outside the intensive care unit? Well, the COVID-19 pandemic made ARDS and MODS a visceral global reality.
We all saw it unfold in real time.
Exactly.
Okay.
Patients developing textbook ARDS, requiring ventilators, requiring PEEP, and needing prone positioning to optimize gas exchange. And a substantial number of those who survived the initial lung phase then developed sequential kidney failure requiring dialysis, along with massive clotting abnormalities. It was the MODS cascade playing out on a scale rarely seen before.
And beyond the recent pandemic, sepsis, which is the most common route into MODS, is among the leading causes of in-hospital death worldwide. It's a huge issue. In 2017, the World Health Organization passed a formal resolution urging member states to treat sepsis as a global health priority, precisely because of how rapidly it triggers these cascading failures.
So to rapidly summarize our takeaways from the sources. First, shock lung is driven by permeability at edema-leaky pipes, not a weak pump. Second, the organ failure cascade acts as a multiplier, where failing systems exacerbate one another through systemic inflammation. And third, the treatments themselves, from fluid resuscitation to ventilator pressures, can actively trigger or worsen the cascade if not managed with absolute precision.
If we connect this to the bigger picture, this raises a really important question. We know that intensive care technology in the 1970s effectively revealed MODS.
Right, by keeping patients alive.
Exactly. By keeping patients alive longer, basic ventilators and dialysis unmasked a layer of biology we had never seen before. Today, we have extracorporeal membrane oxygenation, or ECMO, which completely bypasses the heart and lungs, oxygenating the blood outside the body.
Which sounds like science fiction, honestly.
It really does. But as artificial life support, ECMO, and highly advanced medical technology continue to push the boundaries of human survival, what entirely new layers of human biology and what unprecedented cellular cascades might we uncover next?
That is a wild thought to end on. Thank you for joining us on this deep dive into the cascade of critical illness. Keep questioning, keep learning, and we'll catch you next time.